Welcome to the Reprofiles, where infertility meets injustice and nothing is off limits.
We're two nurses. We're certified reproductive health advocates, and we're here to tell you everything they didn't.
From the broken systems to the heartbreak left behind, we're here to connect the facts, the policies, and the pain.
Because silence isn't safety, and we're done being quiet.
This is the Reprofiles.
Infertility, injustice, and all things nobody warned you about.
Hello, we're back, and you are back. Thank you for coming back. Welcome to the Reprofiles. I am one of your hosts, Elizabeth, board certified fertility nurse, advocate, also a congressional candidate out in Arizona's 5th District.
Yay! And I'm your other host, Anne-Marie. I'm also a board certified fertility nurse advocate, and I'm not running from anything because I have plantar fasciitis, and it hurts. It hurts a lot. Anyway, back in September, when Elizabeth and I were starting the Reprofiles, we had a list of ideas that we were coming up with. So some we've already discussed, and some we're still coming up with, and some were just put on the back burner. One of those ideas was what I titled Fertility Horror Stories. And that's what we're going to talk about today, friends.
Yes, and we do say we're going to peel back the layers and expose that underbelly of reproductive health, good, bad, and otherwise. So this topic is highly emotional on every side of it because it's emotional for the patients, for the fertility staff, but it's also wildly emotional to all the family and friends of these people and the family and friends of anyone who's done fertility. Because I think we start to wonder, has this happened before? So
Absolutely right. We're going to talk a little bit about what clinics do to make sure there's no type of misidentification, and we can also address what could go wrong or how can it go wrong.
yeah, no, as as we learn more and our industry gets older, I think we are continually turning on a dime and trying to learn from things. And headlines sell papers, okay? And we're kind of out of the paper era, but you get what I'm saying. Headlines get clicks, and so of course, something like an embryo mix up is going to, just by definition, get a lot of clicks. What I think we want to dig into is how frequent are these mistakes? Out of thousands and thousands of cycles in a year, how prevalent are they really? And we've been seeing this around. Are the fertility clinics in the US the wild, wild west? Like I live in the wild, wild west in Arizona, but I don't know. I don't think we're there as the field. I think that that's an unfair characterization.
Yeah, I agree. I don't see it. I hear it about fertility clinics in the industry. They're wild, wild, but I really don't see that, and I don't understand where it's coming from. Well, I do kind of understand where it's coming from, but yeah. So while we were discussing this as our next episode, like we had already decided that this was what going to be our topic that we're going to be talking about. So what was strange is like literally days later, a bombshell hit again in our field, and this one was literally in my backyard. It happened in Longwood, Florida. A new lawsuit was filed this month that alleges an embryo transfer that happened in March of 2025 was not a couple's biological child. So after giving birth this past December, so December of 2025, the couple
So last
noticed
month,
so literally last month, yeah, the couple noticed that the baby's physical traits did not match with theirs. So after DNA testing, it did show that the baby was not their biological child. So they were not biologically related to either the mother or the father. So the couple, who has remained anonymous, state that the child should be reunited with their biological parents, which is just heartbreaking to hear. You had a successful transfer, you had that pregnancy test positive, your second pregnancy test positive, your ultrasounds all looked great. You're carrying this baby, for 9 months, and then finding out that this isn't your baby. Pretty devastating. So what the couple is asking for of the clinic is that they want to make sure that immediately notifying all the patients who had embryos in storage before their implantation, and providing them with a copy of that information, paying for free genetic testing of all patients and their children's whose birth resulted from embryo implantation through the defendant, the clinic, over the past 5 years. So, and I think this is an interesting point because the only reason why this couple noticed it is because the baby didn't have physical traits that matched theirs. So, what if their physical traits did sort of match? That's a legit concern. And, and that the clinic also disclose any parentage discrepancies discovered through this testing. So the clinic does have a statement on their website now. They didn't have a statement, but they did put up a statement saying that they are cooperating and trying to determine the source of the error. Now, I don't know if they're going to be doing all three of those items that have asked for, but it's just another like
No. I
bombshell
mean,
that we have to deal with.
it's a doozy. I mean, they all are because they're all it's such a unthinkable sort of
Mhm.
scenario. I mean, last year, similar thing, a woman from Georgia used a sperm donor in her IVF treatment at a South Carolina clinic. And she had an embryo transfer, delivered a baby in December of 2023, and that baby did not share her traits or her donor's traits. So her initial suspicion was maybe there was just a mix-up of the donor sperm, but she was not biologically related to the child either. And, she had bonded with that baby as anyone would. The current
Mhm.
couple in question, like, I think about bringing my children home from the hospital, and those first hours, days, weeks are just there's some of the biggest hours, days, and weeks in your time as a parent. So, this patient had bonded with the baby, but after the clinic was able to locate and identify the biological parents, they sued for custody and they won. And here again, I mean, there are so many people that are unbelievably impacted in just that story.
Yeah. Yeah, I mean, I feel for that woman. She picked out a she did so much to just get to that point, right? She had to pick out a donor, she had to go through all of
Well,
that.
first she had to make a decision that she was going to have do IVF through a donor.
Sure,
I
yeah.
mean, that in and of itself takes guts and, all kinds of just, uh, steps and thoughts that you never really probably figure yourself going to have.
Yeah. I mean, single parent by choice is a tough decision, even
Mhm.
before looking to figure out a donor, it's just being deciding to be a single parent by choice. That right there, that is huge. So every step of the way, and in the end, she doesn't have a child, devastating. I mean, absolutely devastating for everybody involved in that situation. In 2019 in California, again, another mix up between two couples' embryos. They gave birth to each other's babies within a week of each other. So it does look like there was a mix up in the transfer. So, one embryo was implanted in it was in the wrong patient, right? Obviously was and the babies were born a week within a week of each other as well. And after 3 months after both babies were born and they kind of figured out the mistake, the babies were exchanged, 3 months later. Like you said, that's 3 months of bonding. It's 3 months of you're waking up in the middle of the night, 3 months of feedings, 3 months of everything. And then, oh, we're going to switch you back and we got to start all over kind of thing because it's a relationship that you create.
Yep, absolutely. Yeah, I mean, in 2019, that's the same year, I guess, as the California case. There was a patient in New York who carried twins that weren't hers and her husband's. I mean, this type of stuff is really, really, really a patient's worst nightmare and a clinic's worst nightmare. And we should note for our non-lab or non-clinic listeners that in our experiences, like both Anne Marie's and I's experiences track here, the embryology lab has been a place under very heavy security that not everybody, even that works in the clinic, is allowed into the lab. And we're talking about having vestibules of two doors, both of which are password protected. And there's a lot of that type of scrutiny. I mean, is that track for you?
Yeah, I mean, in my experience in the different clinics that I've worked in, it was through two locked doors. And typically, one of them was fingerprint access only, so only people who are fingerprinted for the lab could get in. So it was basically like the embryologist and like the andrologist. The andrologists are the people that handle like the semen analysis and things like that. The REIs obviously are permitted to go in there. And then, other people who are, permitted by the embryologist to come in were allowed in. That was it. No one could just be like, "Oh, hey, I wanna go in the embryology lab and hang out," or, "I wanna go see what it's like." No, you had to get, like, permission, and usually it's like, "Why do you need to come in? Why is the purpose of you coming in?" type of thing. And not only that, just to get in the door, but when you do get access or are permitted to walk in, usually you have to do all, like, the shoe covers and the hair covers and the masks, and some require masks to do all that. Now, at the smaller clinic that I was in, I would be brought in for identification. So I was one of that important step of identification. Just for anybody's knowledge, anytime that an egg, a sperm, embryo is moved or being worked on, two-person identification is required. So two people need to make sure, for example, name, date of birth, patient number, embryo number, if it's there, that all has to be checked by two people.
Even partner name, if
Yes.
there is one,
If
or donor number, if it's a
correct,
donor,
yes.
right? We're
If there's a
downsizing
donor.
now.
Yeah, so there's, like, a thing, and you have to check it, and then you have to sign off that you agreed, like, with the embryologist, whoever was doing the check, typically the embryologist. So that includes anytime that something's being cryopreserved, anytime that something is being thawed as well. They would always need a two-person identification. It's called chain of custody, right? That's what we call it, to make sure that there's no mistakes happening, there's no mix-ups. This is where I'm like, this is not the Wild West. This is pretty very regimented, very like if you don't have a second identification person, nothing's going to happen, right? So it's a very serious part of the lab life, as it should be. Obviously we don't want mix up, and this is why I don't think that mix ups are that common because I've seen it. Um, it's always fascinating to me whenever I'm in the lab, and I've been in a large lab, been in a small lab. I'm with one embryologist. I've been in a large lab with dozens of embryologists, and they're all like specialized and each doing their own thing. It's a pretty sacred place. It's respected as such as well. One false move could spell disaster. And speaking of one false move, so one of the first times I've ever was in an embryology lab, I was in a large clinic. I was there for observation because that's what they had new nurses do, is to go to each department and kind of see what they did. And it was important that the nurses go to the embryology lab to watch what happens in an embryology lab because we are speaking to the patient so we can say, "Oh yeah, I've been there, I've seen this, and this is what happens down there," kind of thing. So one of the first times I was there, so I was standing watching an ICSI procedure, and when I stand, I have a tendency to sway, which I've noticed. One time I did stand in our podcast and I watched it and I'm like, "Oh my god, I'm moving around so much." Anyway, I'm sitting down today, but I have this tendency to sway when I stand in one position. So the director of embryology literally came up behind me with a chair and she was basically like, "Sit." She did not want me moving. She was just like, "I can't have you making weird," not like weird movements, but, just having that swaying motion because people are walking around the lab. They have dishes in their hands. That's how serious these people take it.
Yeah, it's a bit orchestral in nature,
Mhm.
in the way that each person has a role or, an instrument to play. It's like a fine-tuned orchestra that every step is calculated. I
Mhm.
can remember an embryologist I used to work for telling me exactly how many steps it was for her to stand up, turn right, make 3 steps forward, turn left, make 3 steps forward, enter the door, and then make 6 steps diagonally to where the fertility doctor sat. She knew her part. And it's so that's for us, I think you and I, why it's always such a shock to see these types of disasters take place because we've also seen how yeah, I mean, highly controlled, like, in the way that a bank vault would be, right? Extremely, extremely serious about, um, that chain of custody, right? I mean, we even I've gone toe to toe with different, executives about the sperm provider must provide that sperm in person with an ID. Like
Absolutely.
But that's not that and that used to be, like, hardcore, like, everybody did it that way, and I think for different reasons, people got more soft on that, but it's just such so many serious implications that it had to be and I've also worked in really small, like, clinics with a super small lab and clinics with a huge lab, and I remember, like, even this small lab still being in awe of, like, what was actually taking place there was really, really like, it was kind of like an awe-inspiring thing in many ways. But we as you mentioned, you gown up like you're going into an OR because air quality and dust and all things a single hair from your head, there's a lot it's we're dealing with microscopic human cells. And yeah, so my experience in the lab was always one of wonderment, one of reverence
Mhm.
because you don't like laugh and tell jokes and blah. I mean, there is that sometimes when cycles are down and they're doing more of like paperwork and reporting and things like that. But no, when the lab is in session, it's in session.
Absolutely.
And
Yeah.
it's kind of, you know what? This is kind of like Congress. Somebody has to
Mhm.
call it to order or everybody has a role. Everybody knows what they got to. Oh, wait, but that would be a functioning Congress. Never mind. My bad. Ha ha. My
Yeah.
bad.
Yeah. So going back, talking about the partner coming in to provide us a collection, yeah, I was present at a clinic where they had to stop doing, well, they didn't stop doing in-home collections, but they stopped allowing the partner, the patient, you typically the woman, bringing the sperm sample in
Right.
for their partners because there was no guarantee, there was no ID, there was no guarantee that not that we're saying people are lying, but it happens. So, like, after that, if you collected at home, you had to bring your own specimen and you had to have your
Yourself and
picture.
sign a paper that that is yours and
Yes. Yeah.
yeah. Yep,
So that I
absolutely.
I was present with that as well. Oh, I also have a little story. You reminded me when you're talking about the embryo and the quality, the air quality and things. So one of the clinics I was in, obviously smell, odor is a big thing. Like when people do transfers and when they do retrievals, it's always said no makeup, jewelry, contact lenses, or fragrances, right? That was my spiel. Like I still remember it because I just said it. But it was like people would be like, "Oh, can I have lotion?" I'm like, "Well, is it unscented?" "Yes, you can if it's unscented." But if it had scent, no. I've Okay, I'm gonna tell 2 stories because
Do
I
it.
like telling stories. So number 1, first story. There was a story that so the embryology lab was on the 1st floor, the clinic was on the 2nd floor. 1st floor embryology, they had their own little kitchen and microwave. They had, the refrigerator so they could keep their lunches down there, what have you.
Not
Okay.
in the lab, adjacent to
No,
the lab,
not in the lab,
obviously.
just on the 1st
No
floor.
food or beverages in the
No,
lab,
no, no.
just
Yeah,
clarifying.
yeah, absolutely no food or drink in the embryology lab. This is on the 1st floor. Outside of the embryology lab, they had their own little break area. So the story goes is that somebody was microwaving popcorn because,
I knew
popcorn
it was gonna be popcorn, I just knew
popcorn.
it.
It's always popcorn, right? And you know that smell when you burn popcorn? It's pretty bad, right? So apparently the director, the head REI, one of the partners, was furious and just banned microwaves on the 1st floor. Banned them. All the, embryology staff people, they all had to go to the 2nd floor to the break room on the 2nd floor to microwave anything. He banned them, wouldn't allow them because of the odor.
Yeah,
So,
yeah.
that's a
No, I mean,
big
we
deal.
listen, I'll sneak in another quick story. We literally, no lie, used to turn up our transfer room to 90 degrees because our REI practiced in a time where temperature fluctuations mattered, and that was a variable he felt like he could control with 90-degree temperatures. As such, as staff, we had to wear ice vests because
My
it
god.
was I mean, it was really rough. But it was again, that I like that you use the word sacred because it's like there is like a sacredness about the process in which you do all the steps and how critical something like the smell of popcorn or turning the temperature up or down, you know?
Yeah.
Yeah.
It's again, I think we're just going back to it's a very controlled environment. It's a
Yeah.
very, like, no one dared microwave popcorn right on the first floor ever again, right?
Uh-huh,
I mean,
absolutely.
and wearing fragrances. We tell patients this, and I always explain to people, I'm like, well, there's some studies show that odor can have an effect, and usually by then, if you tell them that, they're like, okay, great, yeah, I'll do it. I'll do whatever I need to do. My other story just revolves around a patient who had really nicely smelling hair product. Like, I
Ooh,
think it was a shampoo or whatever. So the doctor made her wrap her hair in a towel before we went for retrieval. So,
listen, I
I mean,
mean,
that's how serious. It's
yeah,
serious in there,
it
right?
it is indeed serious. It's very serious. Well,
Okay.
we should talk about, you know, I
Mhm.
think, like, again, there's this big mythical, mysterious, like, what's behind there? And I think
Mhm.
people assume that there's um, like Costco deep freezers and stuff like that. Like, you think of
Yeah.
frozen, and so, like, teach people, give people some wisdom on what's inside the lab.
Yeah. So, besides all the technology of your incubation and all the little stations where everything happens, I think people want to know, like you said, the deep freezer. It's not the one that you go out to Costco and buy. What in the labs that I was in, they used what's called doer tanks. So these are like specialized tanks. They're kind of big and fat. They look like a little robot, but they sit on wheels. And what these tanks do, they're specialized because they allow for super cold substances like liquid nitrogen, which is what is used in embryology labs to freeze embryos, eggs, sperm, all of that. So the reason why they're on wheels is because they have usually have a locked area where they put the doers in a locked area. If they're not sitting in the embryology lab, and they can wheel them into the embryology lab, like, oh, I need to thaw this, and they wheel that doer into the embryology lab and take out that vial, whatever they need, or the straw. When you open up a tank and you kind of pull it up, you're going to see a bunch of what they call canes. They're like just metal sticks. And on those sticks, there's like different compartments, which is where straws can go in. But that's where they're located. So that's, how they're located in the tank. And then each tank is labeled. And when you open it up, you see there's, I forget how many in a circle, but you know where it is and which cane is on, because each cane has a number on it, and then you go to the straw, and each straw has a number on it. So
Yep.
again, going back to the identification and two people have to be present when that is being opened, when the cane is being taken out, and when the straw is being taken out. So for embryo, eggs, and sperm. Now, that is just one system that, I was aware of. Now there's another, new fancy technologies that are coming out, like the TMRW, I think they say tomorrow.
Yep.
It's a big fancy, like, looking soda machine, I guess you wanna say. It kinda looks like, would you say a
Yeah,
soda
I mean, it's
machine?
yeah, it's a bit like a vending machine, of
Yes,
sorts, a very
yes.
high tech
Yeah.
vending machines. Imagine Dippin' Dots vending machines for embryos. I
Yes, and
mean,
you can manage your
I just,
inventory
you know what?
digitally.
Tomorrow, if you guys wanna use that tagline, listen, as long as Dippin' Dots says it's cool, you're welcome. I no
Yeah,
charge.
there you go.
No, but just to try to wrap people's head around it, because 'cause I'll tell you, even until I saw one of the units physically at an ASRM conference,
Mhm,
I still didn't even quite picture what that was.
mhm.
But it's effectively, as opposed to a person going and getting the tank, wheeling it into the embryology lab, opening it up, identifying, okay, it's tank 12, cane 7, straw 2, boom, 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 boom. You're effectively using technology, using data science and AI probably at some level, and robotics, because what you do is, the embryologist steps up, talk about really secure, like Anne Marie and I, when we used to work in the hospital, there, when you got medications for a patient, you had to, it was like a vending machine. I
Mhm.
forget what it's called. The Pyxis is the one
The
that I'm most,
Pyxis,
like,
yeah.
familiar with. But it effectively is like a medication vending machine, and you walk up and you use your thumbprint, you use your fingerprint, you put in an ID number, and then you only have access to certain patients, and then you say, "Okay, I wanna get this med," and then one little drawer will open with the med
Yeah.
you need.
Pops up, yep.
And so the Tomorrow Machine is, and we should have, I think it's Cynthia Hudson. I hope I don't get her last name wrong. I'm pretty sure it's Cynthia Hudson, but as far as I know, she's still at Tomorrow, and she might be a fun guest to have because she's, I believe, an embryologist by training, but like us, enjoys like forward thinking technology and trying to understand, like, how do we solve these problems? Because we are all human, truly. And there's one thing that will always be true about being human, and is that we make mistakes. And I think that it might be worth just saying that so do computers. Computers are not entirely infallible, but in a situation where something this control needs to take place, maybe something like a digital solution, right? Because pilots didn't always have like super fancy radar systems and all of that, and that's why there were a lot more plane crashes and there were because they but then when they had that technology, air travel was able to sort of I wonder about that. But how do you think, Anne-Marie, how do you feel like some of the errors that happen, how do you feel like they take place? Because again, neither of us has ever been involved or experienced an error of this type at all, sperm, eggs, embryos, birth, any of that. We've never, and collectively between us, we've probably worked at over a dozen different clinics
Mhm.
over the years or supported clinics like that. But how do you feel like some of these mistakes are taking place? Like, where's the ball getting dropped?
I think that I think there has to be an issue with, okay, that two-person identification. There has to be something going wrong. There's gotta be a process somewhere along that line that that's not working. Either they're bypassing a two-person identification, or the when the two people are together, they're not just focused on that particular case. They're maybe chatting about other things, or talking about like, "Oh, hey, how do you think this person's cycle is going?" Or just anything. They could be talking about anything. I mean, they're like, "Oh, yeah, I trust you," kind of thing. Like, they're
So
maybe
that
the embryologist is talking about a name and number, and you're like, "Yeah, yeah, yeah, I trust you," kind of thing, and I'll sign off on it.
that reminds me of something. It just came to my mind as you said that, as we were
Mhm,
talking about the Pyxis and being in a hospital setting, because there are two-person identifier requirements in healthcare in other places.
mhm,
For example, um, before you go into surgery, there's a surgical timeout and everybody stops. And typically, before the patient even goes under, we say, please state your name, date of birth, right? Okay, great. You're here for XYZ procedure with Dr. So and so, correct? Correct. All the providers look at each other. Say to the patient, okay. And then once we have that, anesthesia can begin the process of anesthetizing the patient and the procedure can begin. Now, that I can't say that I've seen any like 'cause well, people do get lax, but what I was thinking of when you said people, of like being distracted or "I trust you," is I remember we used to have to waste narcotics together. I mean, we still do. If you handle narcotics in a medical setting, you are required by law to do certain things, and one of those certain things is, let's say I have a patient that has an order for, let's say, 2 milligrams of morphine.
mhm,
And all we have is 4 milligram cartridges, right? I have to stand with you and we watch each other as I draw out half and waste the other half.
mhm.
But over the years, I remember nurses being like, "No, it's fine. It's fine. Here's my thumbprint."
Yeah.
And I'm like, "No, no, no,
Mhm.
no."
Yes.
Right? The
Yeah,
whole
that happens.
point is that we're double checking, or even when we pull up insulin doses. There was an instance in the hospital where there had been a mistake with an over like too much insulin given. And there was a period of time where even 1 unit of insulin, which is like nothing, nothing, but like even 1 unit of insulin had to be witnessed. So
Yeah.
you'd be at the Pyxis pulling your meds, and if you were pulling Joe Smith's insulin and he needed 27 units, you're gonna say, "Hey, Anne Marie, come here. Is this the right insulin? Yep, right insulin. Okay. Is this 27 units? Yep, 27 units for Joe Smith. Yep, yep. Everybody good? Okay." So yeah, I wonder if that's not it. There's just a level of complacency, and I don't mean that in like a derogatory or negative way, but as humans, we're like
Yeah.
we get we we do get complacent. We get hungry. All of a sudden, you might be thinking about what you brought for lunch and how when you're done with this transfer, you're going to go eat lunch?
Yeah.
And I think too, I hope I'm not jumping ahead, but there is no federal requirement for US clinics to really prevent mix ups or report them. I think fertility has actually shown an incredible ability to do what we do at the highest possible standards, even in an environment where there's a lack of federal federal legislation or even local or state legislation, even in the absence of that, clinics have held themselves historically to very high standards. But
Yes.
with this whole mix-up thing and mishaps thing, and then, like, there's no standard, like, recourse that's guaranteed to patients who are affected by something like this. So that makes me wonder, especially as somebody running for Congress, wanting to pass legislation that improves clinics' ability to do the job well, that decreases or eliminates these types of errors, and that gives patients a sense of safety and security that their clinic is going to be adhering to these standards. So, like, do we need greater oversight? Fertility clinics already do have to file by law. Well, I'm going to say this, and as quickly as I'm going to say it, I might take it back. But with the CDC for reporting ART outcomes, assisted reproductive technology outcomes. However, the agency that was responsible within the CDC to take and process and report all of those statistics, as far as I last heard, no longer exists or
Mhm.
has no funding, or like it was part of the
Something.
hatchet that was taken to the system starting around this time last year. But there's also our own body called the Society for Assisted Reproductive Technology. Clinics have to file with them, but only if they're a member of
Mhm.
SART. So not everybody will elect to do that reporting because reporting takes time. They have to file the start of every cycle, and it has to be documented and filed within, it used to be like within 4 days
Yep,
of
yep.
the cycle. I mean, it was very strict. And I remember my embryology assistants and my embryologist coming to me be like, "Nope, it's happening right now. It's 4 days. I need the date. What's the date?" So
Yeah,
you had to file like when the cycle started, what the person's diagnoses were, what meds they were on,
for
how many
sure.
days of meds they've been on, what doses of those meds,
Mhm,
and then the outcomes, right?
mhm.
Effectively looking at success rates and publishing success rates. And many patients utilize that data to make a decision on like what clinic they're going to even go to in the first place. But should there be, I mean, this happens in hospitals, right? Near miss, it happens in hospitals.
Mhm,
And while the clinics that was a part of, I always required near miss reporting.
mhm.
But that was just me as one manager because I knew I can't fix what I don't know is happening. So,
Right.
should there be some kind of like near miss data tracking that exists in our field that's not there yet?
Well, I think that just comes back to, like, that's a standard nursing thing, right?
Yeah,
You do that because that's very standard in nursing is that they need to find, like, a root cause, right? Even if it
right,
was a near miss, because they wanna improve the system in any way that they can, even if it was, like, no harm was done
right.
to the patient, there was no
That's
mix-up,
why it's
but
called a near miss,
near
right?
miss.
'Cause we
Yeah,
missed, but
so
it was
but it
close.
was close, it was close.
Too close.
Maybe that's something that should be do we need to report it? I don't know. Is it should be internal only? But I think that those types of things should be looked at, analyzed. No one's getting in trouble. And that's the thing with nursing as well, is nobody's getting in trouble. It's just a matter of, hey, let's take a look at our protocols. Let's like take a look at our procedures. Maybe there's something we're missing, or maybe something there's some we can add in to prevent a near miss, to prevent an actual thing happening. So when I was looking up this topic, I found a study that was published in 2024. It's called the Legal Case Study of Severe IVF Incidents Worldwide. So causes, consequences, and high emotional, financial, and reputational costs to patients and providers. And in it, it says that it shows that the UK, they do their Fertilization and Embryology Authority, or HFEA,
Yep.
requires licensed ART/IVF clinics to report IVF incidents annually. It's required. That data is included in their annual state of the fertility sector reports, something that we do not have here in the US. But just because there's not an incident doesn't mean there are not incidences. You know, some may not be discovered for months or even years. Like I said, if the baby has similar traits to someone, that is still an incident that happens. They may not know for years and years and years. So, you know, some of the reporting may not be true or accurate because they just don't know. So in this study, it talks about percentages. Specimen mix ups were actually the most prevalent type in this report. 95% are specimen mix ups. So yeah, I mean, I think that, going back to US fertility clinics, maybe this is something that we should look in. Should we report it? I don't know if it needs to be reported as part of like adding it into the CDC or the SART. I don't know, or just internally. It's something to think about. I think it's a topic that needs to be discussed.
Yeah, I agree. I think at the end of the day, we can often look to Europe for clarity on ways we could improve our healthcare system. I mean, we obviously have the most expensive healthcare system in the world. And, I really am personally just for as absolute little government regulation as is necessary to keep everyone safe and sound and to
Mhm.
prevent harm from happening.
Mhm.
And this is one of those situations where, like we talked about above, there are a lot of people that are hurt when a mistake happens in our lab. As of April 1st of 2023, there were 15 legal cases worldwide on this type of mix-ups. The cases, and 5 of them were specimen mix-up or damage or mishandling or loss and or possible contamination, right? So of those 205 cases, 4.9% of those happened in the US and only 2.9% of those happened in the UK. And then another like 12% or so were in other countries. So again, what do you think this means? Do you think is something amiss with our protocols or is it something else? I mean, by the way, 10 the other 10 cases were like catastrophic scale storage issues, alarm failures, power loss, things like that. I mean, in the study there were 133 lawsuits filed in state and federal courts in the US over from like 2009 to 2019. And in those suits during that period, US licensed clinics performed just under 400,000 embryo thaw procedures, and the incident rate of those was less than 1%. So while we certainly hold the majority of the errors, it's really still very, very key to understand that the error rate is still really low.
Very low. Yeah. And that's what, these stories that come out, again, we go back to the beginning. Yes, these stories are powerful, they're emotional. We're all going to be thinking about it. They come out in the news. I think they come out in the news because they are so few and far between. By bringing them into the forefront, it makes it seem like, oh my gosh, fertility clinics are just willy nilly kind of doing all of this, and
Right.
in actuality, it's a very small percentage. And we are all shocked when it happens. You and I are both shocked that
Yeah.
things like this still happen. So I think looking at this study as well, they found some common factors that have been going on. So we talk about like, how can this happen? So in this study, they talk about human error, embryologists being distracted, like we discussed, heavy workload, multitasking, those types of things. We discussed that. The second thing was, paper records, you know, paper records. I can't stand paper records.
I know.
But handwritten labels, everybody has nobody can read my handwriting. My handwriting is atrocious, okay? It's terrible. I was told I was gonna be a doctor because my handwriting was so bad. So, handwritten labels, things like that. The third thing they found was old or defective cryo storage tanks, the newer tanks that we were talking about. Their alarms were disabled or broken. I mean, this is the things that you should be looking at in your lab, and that most embryologists that I know are going to be looking at, like making sure that those alarms are working or not broken. These are just safeguards. And most of the embryologists I know, I don't think I've met an embryologist that wouldn't take those types of things seriously. The fourth thing that they found, lack or insufficient training of the embryology staff.
Yeah.
So that's important. And making sure that everybody is on the same page. Like you said, when you go in there, there's very regimented, like your embryologist knew exactly the steps to take. This is just, it's such a highly regimented thing, but that can go to lack of training thing. And I just want to talk about at ASRM this year, I actually went to a presentation, a panel. Elizabeth Grill and Alice Domer, they presented burnout treatment and prevention for clinicians in the art field. Fabulous presentation. It was my favorite one of the entire conference. Every slide had me thinking, "Oh my gosh, yes," because they were talking about staff burnout. And so their first question when they came up was like, "Who do you think has the most burnout in a fertility clinic?" And there must have been a million like fertility nurses because that's what came up the most because we had the little phone thing where you can answer the question. Anyway, so the most common one that people voted on was nurses, and I was like, "Yeah, that's right," but it actually wasn't the answer. You know who the answer was?
Let me guess. Embryologist?
Embryologist, yep. Now, I personally would love to be an embryologist. I think it's one of the coolest, no pun intended, jobs. I am so fascinated by what embryologists do, and the whole embryologist field just fascinates me, how they came up with this technology. And I'm going to put a plug in if anybody has not seen Joy, the movie Joy. It shows the beginning of embryology and it talks about the birth of Louise Brown, the first IVF baby. And it shows the beginnings of embryology thanks to the hard work of Jean Purdy, who actually was a nurse first. So go her.
Yeah.
But I honestly don't have the guts to be an embryologist. I think it takes guts to hold someone's dream in your hands. And I'm also not coordinated, as we have seen in my previous story. I would totally trip and the dish would go flying. But it really takes guts to be an embryologist. It takes a lot of emotional
Yeah.
courage
Yeah.
and coordination, but it takes a lot of courage to become an embryologist.
I agree fully and completely. I think that, yeah, I am in awe of embryologists. And that's why we have a special interview coming up with an embryologist. Jennifer Baker's senior embryologist, years of experience, not even just in embryology, but in setting up and starting labs. And well, because their time is so limited, she was only available for a short time. So we will skip to her interview. So Jennifer Baker, everybody. All right, everybody, we're very excited to bring you the interview that we promised. Our embryologist Jennifer is with us, and Anne Marie, I'll let you introduce her since she is a friend of yours or a colleague.
Yeah. So this is my friend slash colleague Jennifer. So we worked in a fertility clinic for many, many years. Probably what 7 years we were together. About we helped open a clinic. So I handled the clinic side, but Jen was the master at opening the embryology lab and getting that up and running. She's had experience doing that in other places as well, but she really headed that section and took everything from what equipment is needed all the way to getting inspections done and completed.
No small feat. As somebody who has done the same, the
Mhm.
amount of items, like the sheer number of SKUs that you need to order to build a fertility clinic is like,
Yeah.
so
And
welcome. We're very happy to have you.
yes,
Welcome to the Reprofiles. Tell our
thank you for
listeners a
doing it.
little bit about your background and what your role looks like today.
Well, I'm an embryologist. I've been an embryologist since 1999. I've been in this field for 20 plus years. I love it. It's like my favorite thing to do. I've worked per diem. I've been a lab supervisor in many places and I've helped open a couple labs. So now I'm just enjoying working, doing embryology. I still love my bench work.
Yeah, I think that's the same for us as well. We while, I don't work in a fertility clinic right now. Elizabeth, you don't either, but we can't leave the field. We just can't leave it. We love it too much. While we try to put our hands in like the field in different ways, we just can't leave it. I agree with you. I love it too much.
I would like to start by asking you if you can help just sort of paint the picture of what identification in the embryology looks like. So, like, you have a patient that comes in. What are the protocols that are most often used, or what do you consider the gold standard for positive patient identification in the laboratory setting?
Most labs don't have the witnessing systems yet. Some do and some don't. So it has a barcode that reads whatever you're doing and that matches to the patient. That's something that's new that's came into our field over the past couple of years. So a few labs are starting to slowly get those. It's very expensive piece of equipment and you also have to figure out how to get it to work in the lab itself. So labs are slowly getting that, but the standard up until now has always been a two-person identifier. So all protocols have two people. You have the person that's doing the task, and then you have somebody standing behind you that is identifying every single step that you do, making sure that each ditch matches the patient that you're working on. And the other standard that we have is you only work on one patient at a time. So even if you're making a dish for a patient, you are making a dish for that patient. You're putting that dish away, and then you're making a new dish for another patient and putting it away. So you're never at any time in the lab have two patients out unless there's other people in other workstations working on another patient. Your focus is always on one patient, and you always have somebody that, and it's not some random person standing behind you witnessing. It's somebody, it could be anyone from the whole clinical, it could be anyone from the lab, but that person has been trained what they need to see, what they're looking at. They know what they're looking at so that they could sit down and they could say exactly what you are doing. And if they don't know how to do that, then they're going to be trained how to do that before they're able to do that.
Jen, do you think that there's, with that two-person identifying, do you think that there is a potential for people to be distracted and be like, yeah, 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 I got a patient ABC, 1, 2, 3, got it. Do you think that there is a possibility for that distraction to happen?
There's always a possibility for distractions. You can say, "Hey, I need an ID over here."
Mhm.
And if you're not paying attention to what that person's doing, is that person really IDing you? As a person in the lab, I always make sure that that person is standing behind me and looking, and that they know what they're seeing, and that I hear them say yes. I want them to interact with me at all times and know that they are seeing and hearing everything that I do. So there is potential for distraction, but you have to also make sure that that person that you're asking to witness for you is available and that person is there. So you may be sitting there and they may not be ready yet. And then you're starting to read, well, you need to look and see if they're ready yet. So that's very important that you always have that. As long as the protocols are there and in place and they're followed, then you're not going to have an issue.
So now, have you worked with these AI systems now?
Have not worked with AI systems yet.
Okay.
We were actually getting ready to install it before I left my last position.
Mhm.
I don't know if they've installed it yet. I know that we were looking at them, so I kind of like looked at different ones to see what they are and how they would fit and integrate into the lab. But as of now, I still have not worked with one. I still do the old system. Someone's always behind me. And, that person is my right hand man. I rely heavily on that person because I want to make sure that, they're making sure that I'm doing exactly what I'm supposed to be doing.
Right. So, Elizabeth and I were talking about, like, what are some of the other potential things that could happen for these misidentification, these things that happen so very rarely but are in the news and it always sensationalized and things like that. So, I've heard of, like, labels on vials and straws that fall off. Like when they put them in the tanks, does that happen? And if so, how do you prevent something like that from happening?
So there is a thing that sometimes I have seen where labels, and very seldom do
Mhm.
labels ever fall off, but I have seen the fact that they do fall off. Most people have a protocol for that because you place your straws in a goblet that has the patient's name on it. You place them in a sleeve that has the patient's name on it. You have so many identifiers to go through to get to that straw. And then even a lot of times on the straw, I mean, I do it still to this day. I write the patient's name underneath the label and the number just because I always want to have that second thing there just in case.
Mhm.
Um, I don't want to have a chance that something's going to be misidentified.
Mhm.
You're always, every time you're in there, and I guess because I've been doing this for 20 something years and I've seen so much, you're always thinking of what can I do to keep from that happening? And that's the mindset that I feel like that we should all have is what can I do to prevent that from happening? I kind of compare it to like these cases that you hear in the hospital, like of someone having the wrong arm operated on.
Mhm.
They have protocols that they go through where the patient actually marks which side that they're supposed to be operating on, you know, but still, yet something still happens
I think
because
we talked about that
somebody, yeah,
earlier in the
yeah,
show, and that I made me think because you're right. I still have the straw that my son once lived on. And there is a teeny, teeny, tiny little label, even like on the
hmm
straw. And so it's in the hospital, we give you one identifier, right? We depend on you as the patient to be there to give us that other identifier. But if you think about an arm bracelet, somebody goes into surgery, you can't,
hmm
once they're under, right? So, and still things happen. So I think what's important to highlight about what you just said, I want everybody to hear clearly, is that the embryology lab handles patient identifiers like 10 times more securely than say a normal system of like, please state your name and date of birth, and I'm looking to make sure it's the same. So there's a lot more steps, a lot more checks and balances because of the what happens if there is a catastrophic mix up. Have you ever, obviously, I know you've never been involved in any mix ups of any kind, but is that something that you think about on a daily basis that could happen? Or are
I,
your
you know,
protocols so tight that you're like, no, I got this now. That's never a concern. Like, help
I
us.
think that as an embryologist, I think you can never feel overconfident. I think you should never ever feel overconfident. I think you should always feel that you need that person behind you, that you need an identifier. I think that's when mistakes happen is if you feel overconfident. And I don't think you should ever get to the point. I mean, I've been doing this for 20 something years and I still learn every day. I still learn new things and I love learning new things. I still enjoy the field. I still enjoy my job. And I still know, like, I still treat it just as I did when I started. I want people to be there to ID for me. I want
Well,
to
because
know
you
that
know
you're
how
the,
effective it is
yes,
preventing mistakes and how critical it is to the overall goal task at hand. But
Yes.
let's talk about, because I think about when I think about alarm failures, I think about a clinic I used to support in Oklahoma City and how the embryologist would actually like sleep on site if there was like concern of like roadway problems with ice and things like that. So talk to us about like the first part of the question is about like how do you handle things like that, like emergency situations, and then like more into alarm failures and things like that. Talk to us a little bit about those protocols, if you will.
we do. Every lab has an emergency preparedness and they handle each one differently. For icy conditions, if we have retrievals or something going on and we need to make sure that we have embryos in the lab, we obviously know that we have a generator, we have a backup. Nothing's going to happen in our lab and everything's going to keep growing perfectly. The main part is, can you get there? So yes, there are embryologists that sleep over. I know I've done it. I've slept in hotels right beside the office plenty of times and not gone home. There was one place that I did per diem. I drove on the road right after the blizzard.
Well,
and,
it's
and,
it's your essential
yeah,
healthcare. It's like,
and there was, yeah,
yeah.
yeah, there was a police station that was, like, right down the road, and they said if I could at least get to there, if I couldn't get into the roads, that they would help me get in. So, we do think about that. Hurricanes, most places, they have a protocol that says when you freeze everything, what do you do? What are you gonna do with your tanks? Protocols are in place for just about every single thing that could happen. I mean, just so that we know what to do.
Yeah, no, it's fascinating because the more we talk about it, the more I'm thrilled that we were able to have this conversation. And I like that we recorded this. So just newsflash, spoiler alert for those of you who weren't paying attention in video, but we recorded this in segments. But I really kind of like that our guest did not hear the first part of our conversation before hopping on here because we very much talked about all the same principles and ideas of how many truly checks and balances there are, how many policies that are in place that have been thought through.
So we talk about, and a lot of people are very worried, and I see the chatter on the Facebook boards of patients, especially in the Central Florida area after the event that we talked about earlier in the episode that happened in a clinic here, the embryo mix-up. I think patients are worried. They're all talking. They're all saying, "Oh my gosh, this is my clinic," or "I wonder if they do this at my clinic." And I think for a lot of people, they just need that reassurance that, hey, you know what? We're not the wild, wild west. We are doing things. We have these protocols, as you have stated. Do clinics do like tank audits for cryopreserved embryos? Is that a thing that happens, or kind of just knowing what your inventory is?
You know, there's a lot of checks and balances that we have to go through so that we can be like inspected. We are always inspected. We're held to a very high standard. And we know what's in our tank. We put it down what's in our tank, and we you don't really actually go and physically check it per se because you're not going to pull them out. And I mean, especially with vitrified embryos nowadays, I mean, if you pull them out, you don't want to just pull them out in and out more than you have to because you want to protect them. But you do take inventories and you do make sure that you know where everything is. So I think the biggest thing is trusting your clinic because the people that hold your stuff, they are taking good care of everything. I mean, I've worked in several fertility clinics all over the US and Canada. And I can say that, trusting your fertility clinic is the biggest thing that you can do because um, the people that work here, they love you, they love their job and they love what they do and they're going to look out for the best for you. I mean, yes, things do happen. I've seen it. Like I've not been in a clinic that it's happened. Thankfully, just trust. Trust is the biggest thing.
So you mentioned like lab certification or inspections type of thing. What type of inspections do embryology labs go through?
They go through several, like some are CAP accredited. So they're
Mhm.
inspected by CAP, which is the College of American Pathologists. Some are inspected by Joint Commission. So SART requires one or the other. If they are, if they report to SART, which is the Society of Assisted Reproductive Technology, if they report to SART, they have to either be CAP accredited or Joint Commission accredited. So they're going to be inspected by one of those. So there are, and they have a huge checklist for us. So we have to go through it and we have to make sure it is just another thing that helps us to keep track of our protocols. Like if we need to update something in our protocol, something like needed to be updated this year or last year, we update it
So how often are those inspections done?
every 2 years.
Every 2 years. Okay. So we talked about also in this earlier in this episode about how embryologists in the fertility clinic actually experience, based on a study, actually experience the most stress
Yes.
in a fertility clinic. And so, they took a poll. I was at ASRM. I was actually at the presentation, and they said, who in the fertility clinic has the most stress? And of course, being a fertility nurse, I'm like, yeah, fertility nurses, we're stressed out all the time. But they actually said that the most stressed out person in the fertility clinic is the embryologist.
I would
Well,
totally
because
agree.
the buck that truly stops with you because even the physician cannot complete the task.
Right.
Only you can.
Right.
So that is a lot of weight, or it's a lot of pressure. How do you handle it? Or how do you not how are you have you experienced burnout as an embryologist?
I don't recommend anyone to go into this business because it is very stressful. Stressful being aside, I love it and I enjoy it and it's rewarding. And that does help me because at the end of the day, I see a baby and I hold a baby that I helped to bring into this world and it makes it all better and all worth it. I mean, it's stressful. Someone's got to do it. So, we're the ones that do it and we hold up. I mean, a lot of people will start off in this field and they don't end up in this field because they can't take the stress too much. So it is one of those fields that, you've got to be
Gotta
able to
love it.
handle. Yeah, and you got to love it. And most of the people that I know, embryologist wise, we love it. And we love the bench work.
I've heard some embryologists describe the inner sanctum of the lab as sort of like
Mhm.
a sacred space even
Yes,
because it is such a transformational thing that's happening. I mean, that's
it's
a
a legacy
pretty
to leave. I
impactful
mean,
legacy for you to
when you
leave.
have when you have a patient that searches you up and finds you on Facebook and says,
"You
my
made my
son's
baby."
20 years old now. and he's living near you. And I'm like, oh, wow. I love to babysit and I love babies. And so I am like always the first one that goes and grabs the baby that's anywhere near me,
No,
wherever I'm at, because I love them. And I love the fact that I help others to have that.
so you mentioned the first babysitter and these babies that you help create. How do you square off that endpoint with folks who are trying to give embryos a sense of personhood or a legal status of personhood? How do we square that off with some of these legal maneuvers that are trying to add those types of classifications to frozen embryos?
I think that a lot of that is because people are not educated. They're not educated as to what is really happening here and what's really going on here. I mean, if you think about it, let's go back to a woman's cycle. She has her cycle naturally. There's so many follicles that are sloughed off during that cycle, and they all go away. And maybe one comes to term and she has a baby, but there's a lot of follicles that went off during that cycle. So when we do our thing, we actually stimulate all those follicles and we bring them into the lab and then we fertilize them. But all of them weren't meant to be a baby. I mean, like I can have three very beautiful, gorgeous blasts and I can put them back into that person and they not take. Or maybe like one of them out of the three takes. I think that is something that we can't decide because only nature can decide that. I mean, that's the only thing. I mean, they're not all meant to be babies.
I've never heard anybody put it quite like that, but that's really well said. I mean, I always say, like, I think of, like you said, the blast, which for those of you who don't know what that means, it's an embryo that's around 5 days old, and it's the stage we typically either freeze the embryo if we're doing frozen transfer, or place it back in the uterus if we're doing fresh. But there's so many more steps, right? If they were all meant to be babies, we would never have heartbroken patients that leave
No, we wouldn't.
empty-handed.
I mean,
We
I've
would
had a
never.
patient that I mean, I can't even count how many embryos I put back on them and how big their fowl was. And the embryos were beautiful and they were euploid embryos and they did not get pregnant
Right.
because apparently it just wasn't meant to be. And like, so no matter what we can do in the lab, it doesn't always take. And they can be picture perfect cycles and picture perfect embryos and they still not take. So we can't decide that every single one of those embryos in our tank is going to be a person because I can guarantee you it's not because I've seen it.
Mhm.
I've never seen a person have 100% of their embryos
Right. So
become
if they were people, they would all make it to be living, breathing people
exactly.
effectively. Yeah. No, that's really well said.
Yeah.
Thanks for going down that rabbit hole with me for a second, just because, you know, I, it's what I come to always land on is that it's nuance. None of this, the rub or the friction comes from wanting to put it here or here. Say
Hmm.
it's up here or down here. You're over there or you're over here. And it's so often out, it's all some mixture of all that.
Yeah. It's all on
We
that
really,
spectrum.
really don't know. I mean, we're just doing
Mhm.
science is not 100%. So
Mhm.
just because we know how to do it doesn't mean it's going to happen.
Yeah. And that's the thing with some of these personhood bills that are coming up as well. Just the personhood itself, having those types of bills where the person who is going to be charged with if an embryo doesn't take or an embryo doesn't thaw properly. These are the things I think about. I think about my embryologists. I think about, like, are they going to be criminally charged because an embryo didn't thaw correctly? And that to me seems very absurd. And I think that that's one of the things that some of these bills, when they come up, I'm like, it just happens. Like some embryos just don't thaw.
I mean, and we see it every day, like with donor eggs. I mean,
Hmm.
that's why there's a guarantee that, because not all donor eggs thaw properly. And
Hmm.
so they're perfectly fertile patients that are donating eggs, but yet for some reason they don't like to be frozen. And you don't know that until you try one and you see what happens. And
What
so
and
there's a
if all
guarantee. Yeah.
Yeah, absolutely. That's really well said.
Well, Jennifer, thank you. Thank you so much for taking time out of your busy day because I know you're busy in the lab and all of that. And we really appreciate you taking the time to kind of
Yes.
like walking us through a little bit throughout the lab and the protocols that you follow that I'm sure that majority or if not all
Yes.
embryologists follow, just to give a little bit more of a look, a little peek into the embryology lab for people who are thinking, oh gosh, what happens in there? It's such a secret place. So we really appreciate you taking the time away and answering questions for us.
Thank you.
Thanks again, Jennifer.